Thanks everyone to give me opportunity to take a lecture on how to appraise the article and evidence-based medicine. Anybody art-loving people, because I like the art a lot. So anybody who can identify this particular picture, anybody from the participant. It is a very famous picture by Vincent van Gogh, and it's a mulberry tree. Okay, so he painted this tree on 1889 with the oil painting. And now you will discuss me why this is not an art lecture. We are going to discuss about how to appraise the article. But I put particularly the mulberry tree because the characteristic of the mulberry tree is that it symbolizes the resilient. And when you compare the wild grass with the mulberry tree, it shows that mulberry tree is a very resilient. So in any of the environment, if the change in the humidity, change in the temperature is going to sustain. So if you compare the fast science versus slow science, so slow science is more of like a mulberry tree. So over the time, it's not going to change its result, but the fast science is more of like more speed, more haste, more stress, and more waste. So most of these critical articles or appraisal of the articles should be like a mulberry tree. It should not change its result over the time. And that's why I put this particular picture. When I was doing DNB critical care, just like you, I always thought of like evidence-based medicine is equal to best research evidence. And this gentleman particularly gave the concept of evidence-based medicine. Anybody from the participant can identify this person who gave the definition of evidence-based medicine?
You can type in the chat box if you want.
Yeah, you can put the chat. It will be more interactive. Yeah.
Sorry to interrupt, but you can type in the chat box all your queries.
Let me check.
Okay. Sir.
Okay. Okay, so let me help you out. This is the person who gave the definition of evidence-based medicine, and that the name of the person is David SUCCEX. So initially, most of time, the evidence-based medicine we always conclude as a best research evidence, but the original definition includes patient's value and clinical expertise. So it's a component of three major components. It includes base research evidence, it includes patient's value, and it includes clinical expertise. That's the complete definition of evidence-based medicine. Now on a Sunday evening, why we had selected this particular topic of how to appraise the article, because there is quite a burden of literature nowadays. And every second, there is a new article published in different medicine journal, critical care medicine journal. So there is an information jungle. And it's very important to screen that which article we have to practice, or what are the articles those are practice changing in critical care. So that's why it's very important that we have to appraise the article. We have to learn the skill of appraising the article. And that's why I thought of, I will take the example or a prototype of this particular trial. Might be you had already discussed this trial in the past. So I'm not going to discuss about the CAPE COD trial, but I will use this trial as a prototype. So we are going to approach how you are going to appraise the article by your own. So whenever you think of such a particular trial, when we do the eyeballing, because that's the word we use in the ICU, we'll go through our eyeballing and first impression that we create with this particular NEGM trial. So it will give us an idea about that it's a multi-center trial, it's a double-blind trial, it's a randomized trial. We had used the control, and there is enough number, particularly when there is a number more than 100, I feel like, oh, 800 patients, that's a good number of patients. And when I see the p-value, it's less than 0.05, and they always make a conclusion like there is a mortality benefit when the p-value is less than 0.05. So with eyeballing, it shows all those great terminology like randomized, control, double-blind, multicentric. So all those terminology we use to try to impress that this is the trial that you should rely on. And when the p-value comes less than 0.05, we always feel like, oh, it's a statistically significant. And that's why we have to start changing our practice. So that's the overall conclusion with a quick response. But if you dig into, then we start with about author. So whenever there is a publication of any of the article, we have to think who is the artist of this particular art. And the artist of this particular art is P.F. Duquesne. So when I dig into who is this particular gentleman, then he spent his whole life in particularly the role of steroid in severe community-acquired pneumonia. So most of the trial in critical care, the steroid plus community-acquired pneumonia, this is the main primary author you will see in most of the articles. And even if you search CAP COVID trial, he is the same person who gave CAP COVID and CAP COD. So he's the same primary author. So he dedicated his whole life in the field of role of steroid in community. So I have a huge respect for this person. But whenever such type of person is involved in projecting a trial, there is an effect that is known as IKEA effects. So he spent his whole life with steroid and community-acquired pneumonia. So his thought process is always a subjective bias to give some positive result, because till now he had published more than 10, 20, 30 published article in a more of index journal. So that's why there is a concept that is known as IKEA effect. So over there, the person is artificially putting a high value on the product or a thought. So here the thought is role of steroid in community-acquired pneumonia. So he's quite biased whenever he's making the hypothesis or creating a trial. And whenever he's going to interpret the data or a data analysis, he's also biased towards the role of steroid in community-acquired pneumonia. So that's why you always remember who is the author of that particular trial whenever you try to appraise. So that is the first thing. So understand the artist of the art. That's the first thing. The second thing is important, where this article published. So obviously there are three holy grail. We always use that word like NEJM, JAMA, Lancet. These are the three holy grail of critical care medicine. Anything published over there, we blindly follow those things because they are highly indexed. And here we mentioned the impact factor of NEJM, it is 96.2 that published in 2023. And it's a peer-reviewed journal. So obviously after publication of the, it's a peer-reviewed and post-peer reviewed over there. But not all the glitters is gold. Anybody can understand, identify this particular person. Let me put those into the chat box. Anyone? So this is Professor Semenza. He got a Nobel Prize, particularly in the field of physiology and medicine in 2019. He got a Nobel Prize, but subsequently he found out that he did the fraud in a possibly 56 article, and he retracted 13 of those articles. So if the fraud happens at the level of Nobel Prize winner also, why the fraud is not possible even in NEJM, JAMA, and Lancet? So that's why we have to be always skeptical, irrespective to whether it's NEJM, JAMA, or Lancet. We have to appraise the article by its our own. So that's very important. So till now we had discussed about the IKEA effect. So we have to understand who is the primary author and what is his background. The second thing we discussed about, irrespective to whether it's a high index journal, whether it's a peer reviewed journal, even irrespective to whether it's a Nobel Prize winner who is presenting that particular trial, we should always skeptical about whether we have to change those practice in our day-to-day thing. So there is a effect that is associated with such type of highly indexed journal or a very mentor or an expert or a professional level people. When whatever they say is we always blindly follow those things, and that is known as bandwagon effect. So what is bandwagon fallacy? So it's a logical error. So when everybody is following particular path, they feel like this is the right path or follow. The other people, they don't criticize those things, they just blindly follow that particular path. So that is known as bandwagon effect. So most of the clinicians rely on ready-made appraisal resources. So whenever I was doing my DNB critical care, I was relying on wiki journal. So whenever I'm going for the exam, I always put the article name, and the wiki journal will give me the idea about these are the good point about that particular trial. These are the limitation of that particular trial. Similarly, we normally student use bottom line. The third thing is a Palmcrete, and we use this tool a lot. But what I insist is that definitely you can go through those tools. It will give you an insight how to appraise the article, but you have to acquire the skill rather than just relying on those tools, because here somebody is taking care of your thought process. So sooner or later you have to acquire the skill of how to appraise the article by your own. And that's why when I was doing my DNB critical care, I thought of publishing an article, and that's why I published this article in 2020. And I tried to make it simplified by making a 5R. So what are those 5R of how to appraise the article? So first thing is the right question. So whether that particular article asking a right question or not, that is going to affect my day-to-day clinical practice. So in right question, again, is subdivided into whether the question is new, whether it's a practice changing question. And the second thing is whether the question having a biological plausibilities or not. So there is an association, causation, and effect over there. The second thing is whether we are dealing with the right population. So whatever the trial carried out, whether they defined the population right. So if they are doing a trial on a sepsis, whether they followed the updated sepsis guideline or not, if they are following severe CAP, severe community acquired pneumonia, whether they follow the IDSA criteria, whether they follow any other criteria to define particular community, if they are doing a trial on ARDS, whether they follow the reviewed definition, Berlin definition, revised or not. So the right population and defined population is very important. After defining a population, whether they are dealing with the sample size adequately or not. So there are again 2 points in the right population. First, defined population and the size of population. Then the third point is right study design. So again, the right study design divided into 2 subtypes. First of all, which type of study design they are selecting, whether it's a randomized control trial, observation trial, prospective, retrospective. The second thing about study design, whether they use any particular tool to strengthen the study design, like randomization is done or not, whether they use control or not, concealment is taken care out or not. So these are the strengthening tool to robust the study design. The fourth point is the right data. So whether they collected the data right. And second thing about the analysis of the data. So whether they use the right software to analyze, whether it's a quantitative, qualitative, categorical data, numerical data. So whether they use the appropriate tool for the data analysis. And the last point is about right interpretation of those data. So most of time we are concerned about the statistical significant thing. So that will be the first point. But that is not the end, because whenever the data is statistical significant, we have to think of whether that is clinical significant or not. That's the second point. And if it is a clinical significant, whether it's a possible or a feasible to apply in our day-to-day practice. So that is about right interpretation. So let's discuss those things step by step. So this is a schematic presentation I made. So in first, right question, as I mentioned, whether the question is new with biological possibilities or not. The second thing about study population, so select the sample size and select sample. The third thing about the study design, where we are selecting whether it's a randomized control trial or observation trial, or whether they followed control, randomization, blinding done, single blinding, double blinding, triple blinding, or allocation and concealment. So that is about study design. The right data, so collection of the data and analysis tool appropriately used or not. And in the end, is the data statistically significant? If statistical, clinical significance there or not, or whether it's a practically applicable. And if everything is fit into a right place, then we have to think of what is benefit versus harm. So if it is a new molecule, whether is there any harm associated with those things, or is there any conflict of interest? Is there any financial interest, post-publication review, and the real world data? So everything we have to consider into. Just to give you an idea about the causality fallacy. So I took 2 examples. What do you mean by biological plausibilities and how it is relevant in our appraisal of the trial? So I gave a first example of male gender having a high mortality in severe care. Okay, that is a historical fact. So if you do the retrospective analysis and if you assess the severe community acquired pneumonia patient, what they found out that the male patient having a high mortality compared to female. But is it a right statement, or is there any biological plausibilities behind it? So if there is no biological plausibility, if there is no genetic reason responsible for this association, then it is just a finding. Okay, so we should not rely on those things. But if you found out a biological process, if you say me that like the male patient having a low immunity compared to female, or if you can say me that the male people having a higher chance of comorbid condition like a heart disease or a hypercholesterolemia, then probably yes. Or might be the male people is neglecting their health compared to female, and that's why they're having a higher chances of mortality compared to female. So we always need some physiological rationale to explain our retrospective or historical data or any of the statement. Otherwise, that is just a finding. It doesn't make any sense. Similarly, I make a second example to understand the causality fallacy is about warfarin. Whenever you use the warfarin, it is associated with thrombosis in early days. That is a fact. Okay, but if I unable to explain it, why it is like that, okay, then it is just a finding. But if I tell you, like when we are starting a warfarin, initially there is a fall in level of protein C and protein S, and that's why there is a higher chance of paradoxical thrombosis. And that's why you try to overlap them with the LMWH initially to prevent this phenomenon. That is one of the reasons. Then probably, yes, that's a biological reasoning of overlapping warfarin versus CLEX until you achieve your INR of 2 or 3. So it's very important that there will be a physiological rationale of your particular finding. So let's start with our first R, that is right question. And in a context of CAP COD, let's see whether they ask the right questions or not. Okay, so whenever I read the CAP COD trial, these are the paragraph I copy pasted from the NEJM journal. So what they found out is this. So CAP is a major health issues, and there is very high mortality despite the advancement in the medical field or critical care field. There is a very high mortality when they goes on the mechanically ventilated patient. That's why it's a very important health problem, and you have to work on it. We need more trial. We need more molecule that is going to change the mortality outcome over there. And what is the biological rationale behind using steroid in pneumonia? So on the left-hand side, you can see the micromolecular level, cellular level, how there is a balance between pro-inflammatory and inflammatory cascade, the capillary leak and the damage or a biotrauma happens, particularly in a community-acquired pneumonia. On the right-hand side, I mentioned pros and cons about using steroid in pneumonia. What are the pros? Why we are using steroid? What is the biological rationale? So it's an anti-inflammatory property, immunomodulator property. But what is the side effect of steroid? So we have to balance. So what are the side effects? Hyperglycemia. There is a high risk of infection whenever you use of prolonged steroid. Psychiatric issues, musculoskeletal weakness. We always think of critical care myopathy, neuropathy, along with other factors. And the mineralocorticoid activities of the steroid, sometimes that is associated with fluid retention. So those are the concern whenever we are using a steroid. Which steroid they had used? So they had used hydrocortisone, and how they justified? So they are telling that it's a natural. So compared to methylprednisolone and other steroids, they feel that hydrocortisone is a natural, and that's why they selected hydrocortisone. And the other rationale they were giving as a physiological reasoning that the anti-inflammatory property and the mineralocorticoid activity of the hydrocortisone is a balance. It is 1:1. So if you think of methylprednisolone, it's a 10:1. So the potency, glucocorticoid potency is 5 and the mineralocorticoid potency is 0.5. So it is like a 10:1. So here there is a more GC potency compared to your mineralocorticoid potency. But for hydrocortisone, it is 1:1. And that's why they thought of selecting the hydrocortisone. But why it is different than the previous trial? So if you read the previous studies or a data or a physiological rationale, we all know that we use the dexamethasone, particularly for airway edema or whenever you have laryngeal edema, whenever there is airway trauma. Particularly in COVID also, we had used the dexamethasone, and it shows mortality benefit. And why the dexamethasone is a better molecule compared to hydrocortisone? Because it doesn't contain any mineralocorticoid activity. And we don't need mineralocorticoid activity to treat a community-acquired pneumonia because you need an anti-inflammatory property. And here, particularly in CAP COD trial, they already excluded the shock patient. Okay, so probably if you are including the septic shock patient, then you can think of mineralocorticoid activity because they are going to retain the fluid, they are going to retain some salt retention, and it's going to affect your blood pressure or vasopressor requirement. But particularly if you are dealing with anti-inflammatory property, then probably the hydrocortisone is not a better molecule compared to your dexamethasone because here you need only anti-inflammatory property, and dexamethasone having a better potency compared to hydrocortisone. So there is a disparity between physiological rationale of dexamethasone use in CAP versus hydrocortisone use in CAP. But in this trial, they use hydrocortisone. Now, if you think about severe community-acquired pneumonia, so pneumonia is an umbrella term, and there are different etiological agents for the community-acquired pneumonia. It varies from bacterial infection, viral infection, other pathogens. And particularly in India, we are dealing with tuberculosis also, and sometimes it's a co-infection. So we are dealing with bacteria, viral, followed by bacteria or co-infection. So does etiology matter? Because it's umbrella term. It's just like a syndrome, like in a sepsis, there are different phenotypes. In ARDS, there are different phenotypes. There are different etiology for that particular ARDS. Similarly, in pneumonia, the etiological agent can be different. And what are the results we get till now about the etiological reasoning? So there is a data published particularly in Chest Journal, the role of steroid in bacterial pneumonia, and they came out to there is no mortality benefit in bacterial community-acquired pneumonia. But we know that there is a high mortality in influenza pneumonia, and particularly in COVID, we found out there is a mortality benefit. So there are three different picture, depends on the etiology. So if you take etiology as an influenza, if you give the steroid, there is a high mortality. If there is a COVID, you give the steroid, there is a mortality benefit. And if you think of bacterial etiology, you give the steroid, no mortality benefit. So yes, the answer, whether the does etiology matter? Yes, etiology matters, but particularly in CAP COD, they just took all the pneumonia from the community, irrespective to whether it's a viral, whether it's a bacterial, gram-positive, gram-negative, other etiology, Mycobacterium tuberculosis. They excluded the influenza, definitely, but the rest of the things they've just included. So that is all about whenever you are raising the question on whenever you are defining the sample or defining particular severe community acquired pneumonia, what are the factors we have to think of? Then whenever we think of PICO formulation, because P is for population, I is for intervention, C is for comparison, whether we use control or not, and O is for outcome. So it's very important that which type of primary endpoint or primary outcome or secondary endpoint they use in that particular trial. So there are more commonly, there are 4 endpoints we use in a critical care articles. One is primary endpoint. So the primary endpoint most of the time is the mortality is the primary endpoint. And whenever you are taking mortality as a primary endpoint, your sample size depends on the previous trial, and the mortality happens with the severe community acquired in the previous trial, and based on which you are deciding the sample size. So your mortality or a primary endpoint will decide the sample size of your new trial. So that is very important. So what are the advantage and disadvantage whenever you are selecting mortality as a primary endpoint? So the advantage is that it is like a unequivocal. So it will give you a very realistic answer, and it's a patient-centric outcome. So it will tell you a patient survived, patient not survived. Okay, but what is the disadvantage of using mortality as a primary endpoint? Because your intervention timing. So if you do the right intervention on the wrong timing, there will be no benefit. So early intervention and late intervention is going to affect your mortality as a primary endpoint. The second thing is that it's a heterogeneity in a critical care environment. So the patient that is coming to the ICU, that they are quite different. It's a quite mixed populations over there, and the genetic structure and everything is different. So that's why there's quite a heterogeneity in your critical care environment, and that is going to affect your mortality. It will dilute your mortality primary endpoint. The second thing is that there is no any fixed timing at what particular point you are going to assess the mortality as a primary, whether it's a 28 days, some of the trial will take 28, 30, 60, 90 days, but there is no standardization thing. So it varies from trial to trial. So that is very important that we have to standardize at which particular point, whether you are going to think of ICU mortality whenever the patient is getting discharged, whether it's a hospital mortality, whether it's 28 days, 38 days, 60 days, and why you had taken that particular cutoff. So that is all about primary endpoint. The secondary endpoint, those are not a decision-making endpoint. So primary endpoint is a decision-making because the sample sizes depend on the primary endpoint. But for secondary endpoint, it will give you some clue. So suppose that particular steroid is not going to affect your mortality, but steroid is telling you it might be your ventilator days is getting less. So that is your secondary endpoint. So in future, you are targeting ventilator-free days as a primary endpoint. So it will give you some pilot project secondary endpoint to do the further clinical research. So it will give you some platform. But what are the disadvantage of secondary endpoint? So whenever you use more than 2 or 3 secondary endpoint, there is a higher chances that there will be a false positive range and there is a false positive p-value. So your p-value will be higher chances of less than 0.05 if that particular trial is using more than 2 subgroup analysis. So that we have to keep in mind. And that particular concept is known as file drawer problem. So it is like a multiple analysis you are doing. So same data you are using multiple time, and there's a higher chances that you will get false positive p-value. So that's the important for your secondary endpoint. The third thing is about surrogate endpoint. So surrogate endpoint is just like example like a lactate for a tissue hypoperfusion in a sepsis patient. So that's the example of surrogate. So here you can't assess directly tissue hypoperfusion, and that's why you rely on some surrogate marker like a lactate. But it's very important that the validation of that particular surrogate endpoint, because we know that there are other factors also that's going to affect your lactate. So if your patient having a liver problem, might be your lactate will be on the higher side. If your patient is on adrenaline, might be the drug effect that is going to affect your lactate. So it's very important that your particular biomarker or a surrogate marker is well validated for that particular illness or a disease process. So that is about surrogate endpoint. And the composite endpoint. So nowadays, particularly in a nephrology trial or particularly in a cardiovascular trial, because the incidence of that particular secondary endpoint is very, very less. So what they do is that if the incidence of the outcome is less, they are going to merge the 2 or 3 secondary outcome, and they gave them a name of composite outcome. And that's why we are hearing the words like MES, that is major adverse cardiac event, and MEC, that is major adverse kidney event. So these are the example of composite outcome. So here you can see MES and MEC. So whenever we are discussing about major adverse cardiac events, so it includes cardiovascular death, it includes non-fatal stroke, it includes non-fatal MI. So if the prevalence of non-fatal MI and non-fatal stroke is less, what they have done, they just mixed the cardiovascular death and they make like a 3-point, and that is known as 3-point MACE, major adverse cardiac event. And they use them as a composite outcome to see the outcome benefit. So, and the other thing about major adverse kidney events, where the death from any cause, need of RRT, and whether there is a persistent renal dysfunction there or not. So if I gave you the example of statin, the problem of composite outcome is that if you are doing a trial, the impact of statin on cardiovascular health, but the problem is that might be your statin is going to affect your non-fatal stroke and non-fatal MI significantly, the percentage point of view. The correlation is more strong. But if you see the statin correlation with the cardiovascular death, might be you will not see the mortality benefit. So the proportion of correlation to all these three components will be varies. It will not be the same in composite outcome. So that's the limitation. So you'll never get the idea how the statin independently affecting these three components. So that's the problem of composite outcome. Similarly, for vasopressin, might be it's not going to change the mortality, particularly in a sepsis trial, but probably it's going to affect your need of RRT. Might be it's not going to affect your persistent renal dysfunction. So the all three components having a different correlation with that primary intervention, and that's the problem. So that's the example of composite outcome. We already discussed the surrogate endpoint, and these are the example. Whenever you are using a blood pressure also for the tissue perfusion, that is also considered as a surrogate, because you are interested in the flow to the tissue, but there is no bedside tool available to assess the flow, and that's why you are relying on the indirect parameter that is like, oh, lactate is going R, or mixed venous oxygen saturation, or a tissue perfusion, capillary refill time. So all those are a surrogate endpoint that didn't give you the direct idea what is the flow at the microcircular level. Similarly, like FEV1 in asthma, whenever you are using a bronchodilator, there is an improvement in the FEV1, and we conclude now there is an improvement in the asthma that is also considered as a surrogate endpoint. This is an example. So there is one trial like inhalational amikacin. So there is it just published like Amin Khan Hal trial. Here, if you see the secondary endpoint, you can see there are multiple secondary endpoints. It's more than 2 secondary endpoints. So whenever you are dealing with such particular trial, when they use more than 2 secondary endpoints, there's a higher chances you will get false positive secondary outcome. And that particular issues is known as file drawer problem. Now we are moving towards our second R, that is right population. So in right population, again, divided into defined population and the size of your population. So in defined population, again, we are thinking of inclusion criteria, exclusion criteria. If your exclusion criteria is large, then the external validity and generalization of that particular trial is going to get limited. So this is the inclusion criteria in CAP-COD. So let me make it more simple. So there are 4 inclusion criteria that so if the patient is on mechanical ventilation, they included. If the patient's pulmonary severity index is more than 130, and there are 2 new things that added over there. So if your patient is on non-rebreathing mask and the PO2 FiO2 ratio is less than 300, they included those categories also. And if your patient is in high flow nasal cannula with FiO2 ratio of more than 50%. But what is the standard definition of severe community acquired pneumonia? So that's the standard definition on right-hand side, where you can see if the patient is requiring vasopressor, septic shock, or if your patient is on ventilator, or more than 3 or equal to 3 criteria in a minor criteria. So if your PO2 FiO2 ratio is less than or equal to 250. So there is a difference between the IDSA criteria and the criteria they followed for a severe community acquired. I'm fine with that. That's fine. They already projected those things. And that is not new in a critical care because if you consider another trial, like a reactor trial, so it was published, and the definition of fever they used was 37.8 or more. But we all know that in critical care ICU, we always target the fever definition of more than 38.3. So most of the trial, they just changed that particular cutoff. So here they changed the cutoff of body temperature to 37.8. So that is not new. But what is concerning, particularly in this particular trial, is that when you go through the supplementary appendix, so what they had done is that, so there are 2 interim analyses in CAP-COD. The one interim analysis they had done at the 400 patient recruitment, and the second interim analysis they are going to do at 800 patient. But when they recruited 285 patients, they had changed the inclusion criteria. So initially, they set as like a PO2 FiO2 ratio of 200. But after including 285 patients, they after predefined thing, you can only change ideally at the interim analysis. You can send the request to your clinical trial team, and if they are giving approval, then you are able to change those things. So that's the first thing I want to highlight. The second thing is that this criteria of rebreathing mask was not there initially. So after 285 patient recruitment, they add this inclusion criteria. Okay. So should we consider there's a breach in protocol? So it is not considered as a breach in protocol because they send it for the approval of change after 285 patient. That is known as amendment. So there are total 10 amendment, 10 particular changes they had done over there. So initially I thought of maybe it's a breach in protocol, but they took a permission from the clinical trial. That's not right, definitely, but the clinical trial group approved it. Okay, but we have to keep in mind they had changed the inclusion criteria after 285 patients recruitment, and that is something known as substantial modification. So whenever you are analyzing any of such trial where they change the inclusion criteria in between, or it is not predefined, you should always be skeptical about the result of those particular things. So that is very important. And that's why I mentioned the hidden truth are unspoken lies, because these are the things they didn't mention in the discussion. If you read the NEJM article, the CAP COD, ideally they have to mention those things in the discussion that we had changed it after 285 requirement. But where they keep these things, they put those things in the supplementary appendix, okay, where nobody is interested or reading to, because those are there. People read the trial, they start changing their practice, but they hardly read the supplementary appendix. So it's very important they have to declare those things in the main original article that we had changed it up. That's the limitation of that particular thing. Now we are moving towards how they decide the sample size. Okay, and that is a tendo Achilles, I will say, for all the critical care doctors. Whenever I initially was doing my DNB critical care, I skipped this paragraph because I hardly understand anything on this paragraph. But this is the most important paragraph I feel whenever you are analyzing any of the critical care article or any of the article. And that is very important. So what they told is that you required 1,146 patients with the power of 80%. So most of the critical trial, they start with 80% of power. And what they mentioned to reduce the 25% relative risk reduction at the day 28, they compared the previous mortality of community acquired. So previous mortality in all those trials was 27% mortality in severe care. So if you want to reduce 25% of 27, so it will come around 20.25. So if you want a reduction of 25% of 27, so it will be 20. Okay, and that's why they calculated, and it come out to be 1,146. And how it comes, I'll show you in a subsequent slide which particular tool they had used over there. So the initial numbers they required was 1,146, but they are unable to recruit it, and they are recruiting 800 patients. That means that is an underpower study. So ideally you required 1,146. And there will be a little bit of attrition also, and that's why they targeted a little bit higher, like 1,200. So if there will be a little bit of attrition, 10-20% over there, at least you are able to recruit 1,146. But irrespective to that number, they end up with 800. So that is very, very less. So it is around 300 or 400 patients less. So even one patient is going to change your statistical significance. So here the number of difference will be 300, 400. So that's very important. So how they calculated that 1,146? So they used this calculator. So if you go by the confidence interval of 95%, it's very important that most of the trial use the confidence interval of 95. But if your trial comes positive, you can go higher also on a threshold. It will be more of robust trial. So there are three cutoff of confidence interval. One is 90. That is like a poor confidence interval. Then the most common one will be like 95. But if you get a positive result with the 95 confidence, probably you aim higher. So it will be 99%. That will be like a more robust thing. But in this CAP COD, they started with 95%. The second thing is about the power. That is 1 minus beta error. That is your power. So most of time, the beta error will be 20%. And that's why the power will be 80%. So that's why I put those value of 80. But if your trial get positive results with 80%, probably you can target 90, 95, and might be 100. That is like a robust one. You are not allowing any of the beta error. And the proportion group 1, the mortality is 27% you are expecting, or in a control group, you are expecting like 20%. So that is like 25% reduction in your interventional arm. And what the sample size you are getting? So one sample size, it's 573. So your intervention arm required 573. Your control arm required 573. So 573 multiplied by 2, that will be a 1,146. And that's why this magic number come into. Okay, but as I told you, if you want more robust, so if this trial comes positive, this trial ideally required 1,146, they end up with 800, and they are telling you some mortality benefit. Even if they recruited 1,146, I will say you should aim higher. So might be your future trial should be of 99% of confidence interval. And if you put those data over here, let me move this cursor here. So if it is 90% of power with the same 25% reduction, probably you are going to require 2,100 patients. So if one sample size required 1,085 multiplied by 2, so it will be around 2,100 patients. So you require 2,100 patients to give more robust value or more robust p value or effect size. So you should not end your practice. You should not end or rely on one particular positive trial, but you should aim higher and higher to get more effective size or p value significance. So that is important whenever you are dealing with sample size. The other important thing is that in CAP COD, the mortality is very, very low compared to the previous severe CAP trial. So here in CAP COD, the mortality was only 11.9%. That is very, very less compared to the previous trial. And if you take this trial as a pilot, and if you want to do the future severe community-acquired pneumonia trial with 25% reduction in the mortality, then you require even a more higher number. That is like 1,743. Okay, so if you multiply it by 2, then probably you require even 3,000, 4,000 number to get the same outcome that you are getting in CAP COD trial. So what are the factors that is going to affect your sample size? So based on this calculator, you already got the idea that the sample size depends on the confidence interval. It depends on the effect size. So here we had conclude the effect size of 25% relative risk reduction, the study power, that is 1 minus beta error, and the attrition rate. Then we always compare the baseline characteristic whenever we are discussing about right population. So if you compare the baseline characteristic of hydrocortisone versus placebo group, you can see there is a difference in the COPD and asthma population. So there is a 26% population of COPD in a placebo and 21% of COPD in a hydrocortisone group. That means the patient who have a COPD in a placebo group, they didn't receive any steroid. They didn't receive even inhalational steroid because they only allowed localized steroid. They didn't include inhalational steroid also. It is like an exclusion criteria. So you can't use inhalational steroid. That means all those patients who have a COPD or asthma who are in a placebo group, and here the number is 26%, but that is higher than the hydrocortisone group, they didn't receive any systemic steroid. The other important thing is about the SOFA score that they use in particular this trial. The mean SOFA score in CAP COD was 4. And if you compare it with the ESCAPE trial, that was a previous trial, steroid severe CAP, over there, the SOFA score was 6. So the severity illness in that particular group was higher, but here the SOFA score was 4. So if you compare the mortality of SOFA score with 4 and 7, it is like 15 to 20% mortality. But if it is like more than 6 or 7, then the mortality goes like 20 or 40%. And that's why probably you are dealing with less sick patient in this CAP COD trial. And this is the inclusion-exclusion criteria of ESCAPE trial, where they had exclude the COPD patient, but in this particular trial, they didn't exclude the COPD. That's the difference between ESCAPE group and the CAP COPD group. So the conclusion is that is the mortality more in placebo group because they made it deprived from the steroid. So all the COPD patients, they're deprived of steroid, and that's why it might be the mortality is on the higher side. The other findings that we see over here, so cumulative incidence of initiation of vasopressors by day 28, who were not initially on the vasopressor. So if you see the hydrocortisone versus placebo group, you can see the placebo groups having a higher numbers. And if you calculate the p-value, because they didn't provide any p-value for this particular subgroup analysis, so I calculated the p-value, whether this is a statistical significant number or not. So if you use that 2x2 contingency table, the p-value for this particular finding is 0.0018. So it is less than 0.05. That means it's a statistical significance. So there is definitely a difference between placebo groups. So over there is a high vasopressors requirement group while compared to hydrocortisone. And those patients are not receiving any steroid in a placebo group. And that might be the contribution for high mortality in particular patients. So these are the two reasons that I found out. One thing is that the COPD patient in placebo group were higher. They are deprived of steroid. The second thing, apologies, sorry.
By mistake, one of the candidates, got unmuted. I've just muted him. Don't worry, sir.
Okay.
Please continue. So sorry.
No worries. So that is about right population. Now we are moving towards right study design. So we always discuss about type of study design, whether it's a prospective, retrospective, case study, case series. We hardly rely on those things because those are very small number to rely on. Then the observational studies, then randomized control trial, we consider those are the gold standard. And we always consider like a top of the pyramid that will be the systemic review and meta-analysis. And what are the tools we use to strengthen any of those particular designs? So we do the randomization. So here they use block randomization, like 4 block, 4:1. The concealment, here they use web-based concealment, electronic. Control group 1:1 ratio that followed, and they did the double blind. So it give you all those good things that we always train, like, oh, if they are done the randomization, concealment, control group, blinding, oh, it's a good, reliable, awesome. Okay, but when you deep dig into, I already told you they had done the at least 10 amendment. Okay, so they had done lots of changes. So when you see it from the superficial global picture, you feel like, oh, it's a very great trial. Okay, but if you go into more deep into how many times they had changed the protocol, I gave you the example, how many times they changed the inclusion criteria. Okay, so I'll give you other examples when I deep dig into. So the duration of protocol. So in an original protocol, they had calculated like it was 36 months. Okay, that was extended up to 77 months. Okay, initially they recruited a 22 French centers and then were extended up to 33 centers. Okay, it is not considered as a breach in protocol, but it required, so to recruit more patients, they had changed the duration and they had included more centers over there. And if you see the speed process of recruitment of those patients, so 33 centers from 2015 to 2020, that is like around 96 months, they had recruited 800 patients and multiple times protocol change. So if you divide and calculate, it will be like 0.25 patients. So every 4 months, they recruited 1 patient per center, or you can include every 4 centers, they included 1 patient per month. Okay, that is considered as a very, very slow recruitment. So what's the problem of slow recruitment? So you can doubt that they are very, very selective about taking those patients, because in 96 months, they're hardly able to take 800 patients. The other problem is that whenever there is a slow recruitment, there's a higher chances that your trial will get terminated prematurely. That happens to your cap COD. And the other reason they normally say is because this trial get prematurely terminated because of the COVID. Okay, but this is the another reason, because before COVID also the recruitment was very, very slow. So those are the important things we have to keep in mind. Now, does steroid protocol matters? That's very, very important, because here they followed hydrocortisone. Here they did the tapering dose of hydrocortisone. That is quite different than the previous trial. So whenever you want to use steroid in community-acquired pneumonia, these are the 5 things you are going to consider. One thing is a type of steroid, dose of steroid, duration of steroid, whether the tapering is needed or not, and the timing of steroid. So this is the protocol they had followed. Like after 4 days, you are going to clinically assess the patient. And if you feel that there is an improvement, then probably you can make it like 8 days. You feel you want to extend it, there is no much improvement, you can extend it up to 14 days. So that's the protocol they had followed. So what you feel about the dose of hydrocortisone? So they had used 200 milligram per day. Do you consider as a low dose, intermediate dose, high dose, very high dose? What the duration of steroid treatment required for the tapering? Do you feel that 5 days, if you give the steroid to any of the patient, does it require tapering? If you use it for 2 weeks, whether it's also affected by whether it's a high dose, low dose, or intermediate dose. So if you use high dose, then you require tapering. If you low dose for 2 weeks, probably you don't require. So those are the very important questions. And if yes, what is your cutoff of how much dose? So these are the couple of important questions that we have to ask whenever you are dealing with the steroid protocols. And then I found out this particular article where they categorize the steroid dose. It's not universally accepted, but at least it will give us an idea about what do you mean by low dose of prednisolone, moderate dose, high dose. So if you convert the hydrocortisone to prednisolone, it is like multiplied by 4 or 5. Okay, so if you are multiplied the 30 into 5, it will come around 120 to 150. So here we had used the 200 milligram of hydrocortisone. So 200 milligram of hydrocortisone is considered as a high dose based on this particular criteria. And what is the cutoff of tapering? So this is the guideline normally they suggest. So if your patient is requiring a steroid for less than 2 weeks, they are considered as a low risk of developing adrenal insufficiency if you are going to stop the steroid. That means here they followed it like for less than 14 days or 14 days. That means you don't ideally require tapering, but in CAP COD, they did the tapering of steroid. So that is something you can debate, like, and the dose is like, and here they mentioned irrespective to any dose. If it is less than 2 weeks, the dose is not important, you don't require tapering. So these are the couple of things we have to keep in our mind whenever you are appraising the article. So dose of the hydrocortisone in this trial, 200 milligram, as equivalent to 50 milligram of prednisolone, but was given for less than 2 weeks that we already discussed. The other thing that they didn't include in CAP-COD original article, but when you go into the supplementary article, so they say is that they didn't include septic shock, are not allowed at the inclusion criteria. But they made some exclusion, and this exclusion thing they didn't mention in the discussion. But if you read the supplementary article, what are the things they excluded? That means after intubation, if the patient is requiring noradrenaline, but the noradrenaline requirement is less than 0.25 micro kilogram per minute, then probably they'd included those patients. Okay, ideally you should not include it based on this highlighted thing like septic shock are not allowed at the inclusion. But what they concluded it is, if it is related to sedation, if it is related to positive pressure ventilation, then based on physician findings. So here we have to keep in mind that give rise to a observational bias, because that is very subjective. As a physician, I feel that might be related to sepsis. Somebody will feel that, oh, it's a sympathetic activity. Now we had given the sedation and that's why you are requiring a noradrenaline. So there is an observational bias associated with this particular forbidden treatment. The another thing that you can observe is the blood lactate level. And what cutoff they made? So lower than 4 millimole. So if it is less than 4, they are not considering them as a septic shock. They feel like it is more related to your sedation or positive pressure ventilation. But if you read the survival sepsis guideline, the cutoff of septic shock lactate is 2, it's not 4. So where this magic number of 4 came from? So definitely they played with those things. And 0.25 microgram per kilogram per minute of noradrenaline is not considered as a low dose of noradrenaline. Because for a 50 kilogram of patient, if you calculate, normally in UK, we dilute it into 250 ml. In India, we dilute it into 50 ml, but we use 4 milligram or 8 milligram in 50 ml. Over there, we use 20 milligram in 250. But ultimately, it is considered as a high dose of noradrenaline. That is like 9 ml per hour if you go by ml per hour. So it is not a low dose. So that's the conclusion we had made. The other findings about the premature stopping of the protocol, this is also not included in the discussion. This is also in the supplementary appendix. So initially they plan to do this trial or extend this duration for 14 days and 8 days. But if you see both the group, it is 5 days and 6 days. So they only gave steroid in a hydrocortisone group for 5 days or in a placebo group for only 6 days. So they never use it for 14 days. They never used it for 8 days. So if you extrapolate or if you are starting practicing in your patient by using a steroid for 14 days or 8 days, might be you are not going to get the same outcome. Might be your patient will die because of higher secondary infection, because in original trial, most of the patient, particularly 75% of patient didn't complete it up to 14 days or 8 days. Only 25% compliance with 40 days and 8 days of treatment. That is very important. They excluded the influenza, but if you see over here, there are 12 patients in both the groups, and that's why they stopped giving steroid in both the hydrocortisone and placebo group. And in 70% and 20% of the patient, it is open label corticosteroid therapy, and that's why they excluded them or a premature stopping done. These are the things we already discussed. So majority patients received for 5 to 6 days only. And this is not new. The protocol violation, you can say so, because there is a Blink-3 trial that published recently, particularly pertaining to intermittent infusion versus continuous infusion. So over there also, 1/3 of the patient, that is like 34% and 32% patient, having a switch over of protocol violation that you can see in the CAP-COD also. Now we are moving towards right data. That is about collection and analysis. And over there, we are going to discuss about how they are going to do the P hacking. And they always says that if you torture the data long enough, they will always confess. And how we are going to explain those things. So we already discussed about the IKEA effect. Now we are going to discuss about Texas sharpshooter effect. That means we are going to do the statistics first. And we feel that after 800 patients recruitment, if there is a difference between these two group will be like 20 and 40, then the p-value will be less than 0.05. So we are going to terminate, or probably we are going to do the interim analysis at 800 patients. That will give me indirectly the whatever p-value I want. And that is known as Texas sharpshooter effect. That means I'm going to target my thing first, and then I'm going to do the analysis around that retrospective analysis that I had done, and I'm going to prove my point that steroid is going to work, particularly in severe CAPE. So this is the example. So again, if we put a calculator over here, pertaining to the CAPE COD, so 25, particularly in a control, in an interventional arm. So there is a good outcome in an interventional arm. That's why only mortality happens of 25. So there are total 400 patients in intervention arm. So 375 and 25. While in a control arm, there is a 47 death happens. And over there is a 395 patient. So it's a 395 patient versus 400 patient as an inclusion criteria, out of which the difference of mortality is like 25 with the steroid group and 47. So if you put those numbers, you will get the p-value that is significant. And that's why you are telling that the CAPE COD trial and the mortality benefit. Now, if I play with the numbers with the calculator, and if I change the numbers of 31 from 25 to 31, so it's a change of 6. Remaining number will remain the same. That means if I add 6 patient over there, so move from 25 to 31, your p-value become significant to non-significant now, because now here the p-value is 0.0516. And that's the concept of fragility index. So what is fragility index? That means if you are adding a patient over there, how many patients you are required to change your p-value from statistical significant to insignificant. That number is known as fragility index. So for this particular trial, the fragility index number is 6. That means it's a very small number. You prematurely terminated rather than 1,100 patients. You prematurely terminated 800. So if you add that 300 patients, probably you are going to change a totally different outcome, because even by adding 6 patients, you will get a different p-value. So by adding 300 patients, might be it's a totally different outcome. Nobody knows whether it's a positive or negative. So that's why this trial and the effect size of this trial is very, very limited. And that concept is known as p-hacking. And that is not depends on your clinical context. So what I do is that there is a table. So I will buy or hire a statistics. They will come up with this number, and I'll plan the interim analysis. So I will say at a 400, I will do those things. At 800, I will do it. And if the p-value I get at 800, probably I will terminate those things to get the desired p-value I want. And that concept is known as p-hacking. So whenever you want to analyze any of the trial, you rely on a randomized control trial first, and then you think of meta-analysis. So if we see the previous trial based on the same topic, so this is the meta-analysis they had done. But as I mentioned, one bad apple spoils the bunch, because your meta-analysis is a bunch of different apples. So if one apple is bad, probably is going to affect your whole meta-analysis. So if your decay in 2023 and the contribution of this trial is 20.3, because here the number of group of patients is 400 and 395. If you see the other trials, their contribution is very, very limited. The other major trial was Maduri trial that was done in 2022. These are the two major trials that is going to affect your meta-analysis outcome. So if you are adding the decay in 2023, it's going to affect your meta-analysis also. So your meta-analysis depends on what trials you are including and what is the robustness of that particular trial. The other important thing is the heterogeneity about the trials that you are including in your meta-analysis, and that is known as I-square or a heterogeneity score. And they always says that if it is less than 25%, the heterogeneity is not that much. So for this particular meta-analysis, they calculate the heterogeneity of 12%. So by eyeballing, you feel that, oh, that's very good meta-analysis because the heterogeneity is not there. But if you go next, let me go next over here. So these are the trials they included in the meta-analysis. Here you can see there is a wide variety over there. So they included the non-ICU patient also. They included any severity of patient also, that not necessarily the severe CAPE. So it can be mild, moderate, severe. The patient can be there in the ward also. And here they use a different type of steroid. So if you include all those trials, probably your heterogeneity will be more, because here they mention only 12%, that I doubt, because here there are non-ICU patients also, probably that will not fit into your category of severity. And here there are 4 trials that goes by any severity. Okay, so there is quite a heterogeneity. So I don't know why the I-square is only 12%. So that's the another important thing. Whenever you are dealing with meta-analysis, we always think of gray literature because meta-analysis always includes randomized control trial, and we always feel RCT are the best. But it's very important that you include observational studies also, you include gray literature also, the literature that is not published, probably like a thesis or other articles or a local audit project or local audit finding. So those are known as gray literature. Those are not published in your high index journal. And that will give you a real result of meta-analysis, whether that particular intervention is helpful or not. But here, they only included randomized control trial, not an observational study or not a gray literature. So it's very, very important that your meta-analysis outcome depends on how many articles you include and the quality of those articles. And the other important thing is that your I-square is a time dependent and it's not an absolute measures and it's not reliable in a small meta-analysis. So that is not a holy grail to define the heterogeneity in a meta-analysis. Now we are moving towards our last point, that is about last R, that is right interpretation. And we always start with whether the data is statistical significant or not. And we always discuss about null hypothesis and the p-value. So whenever we ask who knows the p-value, everybody will tell yes, the p-value less than 0.05. But when we ask them, how will you explain the significance of p-value and how, then it's very difficult because everybody remember the number or a cutoff, but what the p-value exactly suggests is very difficult to express. And the reason for that difficult explanation and the problem around the p-value is because of this gentleman, that is Ronald Fisher, who gave the concept of p-value. So what originally he told that, and why we are dealing with cutoff of p-value of less than or equal to 0.05, because that's what all the scientific community and journal editor use. And why they use those things? Because whenever they are doing their graduation school or college, everybody told them also like the p-value cutoff should be ideally less than or 0.05. But what ideally the Ronald Fisher told us is that the p-value will only give you a signal. So if your p-value is less than 0.05, it will give you a signal that probably you should do more robust trial in a further, probably it will give you a signal that you should do again and again to get a more effect size. So your p-value will not tell you the effect size. It will tell you some clue that there is a difference between the numbers between these two groups, whether intervention and control. The other important thing is that based on p-value, we should not decide our scientific conclusion or a policy decision making. And the p-value does not provide a good measure of evidence regarding a model or hypothesis. So the conclusion is that the p-value offers only weak evidence or suggest against the null hypothesis. And from where this magic cutoff came from, less than 0.05, because there are other cutoff also available. So in a genomic testing particularly, because there are multiple possibilities there in a genomic things, they accept this very stringent p-value. So they are accepting a p-value threshold of 0.000. How many zeros are there? 3, 6, 7, 8 zeros. So the 0.05 is a very random number. So it depends on whether you are going to get more and more robustness. So in a genomic study, they are following this cutoff. And that's why there are more and more articles coming into the picture that probably we should change our p-value threshold. And that's proposing probably we should accept less than 0.05. We should accept 0.005 p-value for more robustness. Now, is there any other alternative approach rather than p-value? Because we are criticizing the p-value a lot nowadays because we are telling that the p-value is not reliable. So is there any alternative way? So this is the gentleman. So this is the Thomas Bayes. Okay, who gives the Bayes theorem. So that is the alternative of p-value. Okay. So it works on multiple hypotheses. So it includes multiple hypotheses rather than just a null hypothesis. And it includes all this prior probability rather than just a cross-sectional relying on one particular trial or p-value. It includes all the previous trial or a likelihood of that particular molecule for that particular etiology. So if you want to study steroid and severe community equipment, they will include all the previous study and what is their likelihood to come positive and compare your study with the previous probability. And they come up with one number that will give you a signal whether it's a strong correlation, whether it's a weak correlation, or it's a very, very strong correlation. So that was a concept given by Thomas Bayes that is known as Bayesian analysis. So that is the alternative of your p-value or null hypothesis. So it's very difficult to explain, and that's why I put this particular picture. So that is Annapurna, and that is the most difficult hiking thing in the world. So on the left-hand side, there is one peak Okay, so if that peak is a p-value, okay, there are lots of peaks. So if you want to reach to the highest level of Annapurna, and if you label that highest peak as a Bayes factor, okay, then this first peak is known as p-value, okay, and this all other peaks is considered as a posterior probability. Okay, so to reach to the Bayes factor, okay, you have to do the lots of testing, or you require the lots of positive trial, okay, to rely on your Bayes factor. So that is like an analogy to give you a rough idea that your p-value is a cross-sectional thing, while your Bayesian analysis will include all those previous peaks that you had achieved, or a likelihood of positiveness, and compare it with your particular trial. So that is your Bayesian analysis. And that's why the deep learning or AI and all those tools rely on your Bayesian analysis. So if you put a data in your AI or deep learning about the steroid role in a severe case, it will give you a Bayes factor, like these are the previous trial. This is the probability or likelihood of positiveness. This is the conclusion of this particular cap theory trial. And this is a ratio. And that's why this is the Bayes factor of that particular role of steroid in severe case. And this is a comparison of p-value versus Bayes factor. So Bayes factor will give you a effect size, why p-value can't give you the effect size. It will tell you there is a difference, but what is the difference, whether it's a 1, whether it's a 5, or whether it's a 10, it will not tell you those things. And p-value doesn't consider alternative hypothesis, but the Bayes factor will include null hypothesis and alternative hypothesis. Then p-value include observed data versus hypothetical things, while Bayes factor is relied on observed data, so it is more objective by nature. Then Bayes factor is more complex. As I told you, it required more computation project or AI or deep learning compared to your p-value. And the intention of the researcher is going to affect your p-value, because they can do the p-hacking, as I told you, by with the help of statistician. But the Bayes factor is not affected by the intention of the researcher. So that's the difference between p-value and Bayes factor. And that's why I just put that picture of evolution of the how we are going to use this statistical tool. So initially in the older days, we just rely on a p-value, but nowadays we are more and more rely on the Bayes factor rather than just p-value. So did anybody done Bayesian analysis on this particular topic, like severe cap and steroid? So yes, it published in 2024 in Annals in Singapore. And what's the probability they found out? So 94.3 probability. And what's the conclusion they made? So overall posterior probability of 94.3% suggest that steroids are more likely than not to improve mortality. Now, how to interpret those data? That means if the probability is 50 to 75%, that is like barely worth a mention, that probably your molecule doesn't having the correlation of the outcome benefit. If the percentage is 75 to 95, it gives you some positive signal. It doesn't tell you that there is a mortality benefit, or can you start change your practice by using steroid in severe cap. But it will tell you there is some positive signal of using steroid in severe cap. But you need more trial, more robust trial, more meta-analysis, more RCT with more confidence interval and alpha and beta error, and then come up with 95 and 99%. That is like a strong correlation of role of steroid. So here, what we got, 94.3, that is like a positive signal, but it doesn't tell you a strong correlation over there. Now, to give you an idea about that statistical significance is not equal to clinical significance, I took one example and we'll calculate in the calculator. So if there is one particular drug, we label them as a drug A, suppose ramipril, we are using in an antihypertensive patient. We are taking two groups, like similarly here, like 800 patient, 400 and 400. And we use the ramipril and we found out, we derived the data. At the end of the data, group 1, where we use the ramipril, find out that there is a blood pressure lowering to 139. In a control group, it's 140. So there is a difference of 1. So in ramipril, suppose, or a like new molecule of antihypertensive medicine, the blood pressure is 139. In other group, blood pressure is 140. And if I calculate the p-value of this group, you can see the p-value is less than 0.01. Okay, so should you start utilizing such type of new antihypertensive medicine in your clinical journey? Because the p-value is positive, it's less than 0.001, it's quite significant. Okay, but we don't do those things, okay, because we are not a statistician, we are a clinician. That the difference, whether it's a clinical significant for you or not, you will say probably 1 mmHg is not a significant. But if you ask the statistician, and if I don't tell you the clinical context, it just hide those things. Okay, and if I tell you just a p-value is significant, okay, and you will say, oh, it's probably a very good molecule antivirus. So it's very, very important that the statistical significance is not equal to clinical significance. And that fallacy is known as McNamara fallacies. That means if you rely too much on a statistics, you will lose the large picture. So all those researchers who are publishing those NEJM or a Lancet or a JAMA trial, normally they do under particular rooms on a computer with the help of statistics, with different centers, they make the protocol, send it, but they are not aware of the real clinical scenarios. And that fallacy is known as McNamara fallacies. That means you are too much rely on statistics, but you are not correlating it with the clinical findings. Okay. And what is clinical significance? So you should more rely on effect size rather than p-value. You should consider the side effect of that particular molecule if the p-value and clinically significant. You should also think of cost effectiveness of particular molecule. Particularly, it's important, particularly if you're thinking of ECMO in an ARDS, then you think of cost effectiveness, whether is there any mortality, even if the p-value is significant, even if it is clinically significant, sometimes it's not feasible to do at the ground level. Then the availability of that particular molecule. Here, the dexamethasone is available, hydrocortisone is available. So there is a feasibility, is availability, but might be the ECMO is not available. So that is also very important aspect whenever you are dealing with the interpretation of those data. And the real world data and effectiveness, that's very, very important. Particularly in a COVID, we had seen sometimes they come up with hydroxychloroquine, they come up with ivermectin, but when you translate it into the real data and you found out, oh, probably that molecule is not important. Similarly, in a Zygris, like in 2004 and in 2005, in survival sepsis guideline, there was a trial that come up with like, oh, the Zygris is going to give you a mortality benefit in a severe shock patient. But when it turned into a real world data, you found out there are more complications rather than benefit. So it's very, very important that you rely on a real world data and effectiveness also after clinical significance. How you are going to assess the effect size? So you can use odd ratio, relative risk ratio, you can use need number to treat, or Cohen's d whenever you think of meta-analysis. So those are the things that is important whenever your p-value is significant. Now, the other important thing, particularly in a critical care literature or particularly in a biology or medicine field, is a reproducibility crisis. So they carried out, they asked 1,500 scientists, okay, they found out that they gave the data that 52% of scientists feel that they are unable to replicate. So there is a reproducibility crisis, particularly in a biology or in a medicine. So 52% of the scientists feel that we are genuinely feel there is a reproducibility crisis. So if the one trial come positive, just like accuracy trial, like neuromuscular blockage and ARDS, it will show mortality benefit. Then the other trial come up like rose petal trial, it will give, there is no mortality benefit. That means there is no reproducibility in a same molecule on a same topic. So that is known as reproducibility crisis. So that is genuine. And why that happens? So they gave the different reason. So most common reason is a selective reporting, publications bias. The other reason is a statistical power. So they use low statistical power that happens to cap COD, and the fraud is also 40% in most of the cases. And this is a comparison of different field about the reproducible crisis. So it's very good in chemistry and physics. So if there is a cutoff of line, there is a red line, that is a 50% cutoff. So any of the cutoff more than that is more than 50% reproducibility. So that is very good in chemistry and physics, particular that field. But if you compare the biology and medicine, the reproducibility is very, very less compared to chemistry and physics. So reproducibility is real, and that happens because of multiple reasons, as I mentioned over here, because of selective reporting, publication bias, and low statistical power, fraud, and insufficient peer reviews in a medical literature. So at the end, whenever there is a statistical significant data, so if we carried out an original study and if we found out there's a good effect size, here the effect size is 0.6. What will the first step, how you are going to approach? So what we are going to do, we are going to see what were the previous data or a posterior study, or what is the likelihood of steroid in a severe case, whether it's showing a positive signals in a previous data or not. If yes, what I will do is that I'll put quite a skeptical sufficiently. That means I'll try to strengthen my trial with large number of a group population with a good alpha error, beta error, more stringent criteria, confidence interval of 95%, and then I'll do again the study. Okay. So, and if that study also give me a replicability, like a positive signaling on the steroid, then I'm going to change my clinical practice based on it. So first step, Do study, positive result, think of previous posterior probability or a likelihood, go for Bayes factor, do the trial with more alpha and beta stringent criteria, confidence interval of 99 rather than 95%, replicate the study, and show whether the result is correlated with your previous one. To summarize my talk, we discuss about the IKEA effect. So author is very, very important. We discuss about bandwagon fallacy. That means you have to appraise the article by your own rather than just rely on a bottom line or a wiki journal or any other ready-made appraisal of the article. Biological rationale is very, very important. You have to think of inclusion and exclusion criteria. What definition they had used, whether they violated any protocol, whether they used the sufficient sample size, what are the endpoints they had used, primary endpoints, secondary, surrogate endpoints, and a composite endpoints. Any bias, whether is there any observational bias, publications bias, and the effect size. If your p-value is significant, focus on your effect size, whether they projected need number to treat, whether they projected what is the relative risk hazard ratio, and the reproducibility of the study, and the Bayes factor. So in the old days, this is the traditional evidence-based medicine pyramid. On the ground level, it will be a case control, case series, then there is a randomized control trial, then there is a meta-analysis and systemic review. This is a new pyramid, EBM pyramid, where they says that the top of the pyramid will be a thoughtfully conducted studies of any design, okay, and the lower trial will be the other seat, okay. I modified again that pyramid. So ideally, the evidence is categorized into thoughtfully, well-conducted, any design with right interpretation and reproducibility, while remaining thing is not reliable at all, irrespective to whether it's a meta-analysis, whether it's a randomized control trial. And sometimes if you feel most of the landmark trial happens at the observational study level rather than the randomized control trial. So either it could be thoughtful, well-conducted, any design, even if it is observational trial, but if it is well-conducted, without any bias, with right interpretation, and if you are able to reproduce that observational study's finding, even I can more rely on an observational study rather than the randomized control trial or meta-analysis. So that is all about how to appraise the article, and you can scan this one to give me the feedback, so I can improve my communication and my lecture. So that will help me a lot.